The first talk this morning is Extirpative Therapies for Hepatic Lesions by Dr. Carlton Barnett, who's a professor of surgery in the Geitz Division. Carl is actually a native of Colorado, and I think he was born right around the corner from me in Englewood, and went to Baylor for his undergraduate training, and then came back here for medical school at University of Colorado. He did his general surgery training here, and then went to do a fellowship at MD Anderson, the General Surgical Oncology Fellowship, and somewhere along the way also completed a trauma and critical care fellowship at Denver Health. His first job was actually at MUSC, spent a couple of years there, and then was recruited to UT Southwest, spent a couple of years there, and then came back to the University of Colorado, where he's led multiple surgical oncology programs, first at Denver Health and now in the VA system. Carl really is the triple threat and has managed to be highly successful in all realms that we traditionally think of. He has over 100 peer-reviewed publications and many other types of publications. Very successful at getting grants, both from the U.S. government as well as from industry and institutional grants. He's an excellent clinician, and our residents and other faculty love operating with him. So today the topic is the liver, and Carl, we look forward to your talk. Thank you.
Thanks, Rich. So appreciate it. Hopefully we can make this work. We had a little bit of AV difficulty this morning, and I assume since I sound pretty loud to myself, everybody can hear me. Obviously, this is kind of a tough topic to take on in such an august crowd with two divisions dedicated with a lot of energy to taking care of liver disease. But I'd like to run through some cases and talk about some principles of taking care of hepatic lesions that I've run into. I was impressed with Dr. Bach's talk a few weeks ago. I think it's been recognized, obviously, for centuries that the liver is kind of a special organ. Dr. Bach talked a lot about using whalebone and all kinds of techniques that people develop to stop bleeding, which is a little intimidating, but after thinking about some of the advances in technology in anesthesia, I'd like to retitle our talk today, Prometheus Unbound. I think that we can safely address the liver, and I'd like to talk a little bit about that. I do have some disclosures, no financial disclosures, but I think it's important kind of when we go through these topics to remember that this is empiric therapy, and these are studies that have been put together that are empiric. I learned about the definition of empiric therapy from Dr. Perlman, and this is not actually a quote, but a paraphrase. I'm sure it was more colorful than this and probably explained to me during my third-year residency, but coming out of the lab, saying we do things the way we do because they work, blah, 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 something about the lab, Dr. Perlman. Thank you, Dr. Perlman, but I think you're right. I mean, we get a lot of, this is 50 patients, this is 100 patients, and we try to make decisions based on expertise rather than just pure science. Well, extirpate is a word that I ran into down in Houston. I don't know if it's because they didn't always get negative margins or why they like this. It was obviously a place that we started doing a lot of radiofrequency ablation, but the definition is a forcible or violent removal of something, not necessarily immediate, which would fit obviously with some of the ablative techniques that I'll talk about today. So I'd like to just briefly go through surgical anatomy that we use when we make decisions, talk some about biological principles, which I think are important and sometimes lost when we collaborate with engineers on things that we're trying to do in terms of taking care of cancer, and then talk a little bit about some strategies that we have been used, maybe make some of the data clear in that regard. So you can't give a surgery talk without showing some nice cartoons of surgical resections, and I think people are fairly familiar with this, and you look at these cartoons, you think, oh gosh, that's not that hard. I mean, these segments are all numbered and they're nicely colored, and so I can just take out whatever I need to. The reality, obviously, is that the liver has a pretty complex internal anatomy with both inflow and outflow vessels that you need to be familiar with prior to taking on cases or planning operations in regards to complications that you could run into in the operating room. The other thing that makes it a little bit more complex, and Dr. Bach kind of talked about this, is beyond just having a complex internal anatomy, the actual liver itself can be quite different. So you can see on screen right, this is a nice soft liver. We're putting a Lin clamp across that to perform a right hepatectomy, and this allowed us to take our time and explain the anatomy a little bit. On screen left is a pretty typical liver you might see at the VA or Denver Health, where it didn't look too bad on the CT scan. It was pretty clear where the lesion was. Then you put a scope in, and it looks like the moon. You really can't get the ultrasound to adhere very well to the surface, and this thing is rock hard and pretty hard to deal with. And so that, I think, experience is going to affect recommendations and things that you're going to say to people in conference. And sometimes anatomy is important because people have bad luck. This is a patient that got referred in from a small Texas town to MD Anderson. Guy's in great shape, has a single colorectal metastasis, and we think you guys can take care of it. And unfortunately, when you look at the films, this guy had a lesion that just happened to dump right between the right, middle, and left hepatic veins. So he's not going to be somebody that we could resect for cure. Yeah, I think everybody kind of knows this, but it's just important to go over when you look at films or talk about cases in conference. Just some general rules. You got to have inflow and outflow. You need a portal vein branch. In most instances, you need a hepatic artery branch coming into whatever's going to be left after you get done resecting the liver. This can be helped, obviously, if you've got an accessory artery. You need one outflow vessel. So you got to have a hepatic vein. You got to have a bile duct coming out so that this thing will work when the patient gets done. And occasionally you have an accessory right portal vein that will allow you to perform some different operations than maybe I showed earlier in the diagrams. And then finally in the end, we talk a lot about synthetic function. And there's a lot of different scoring systems that people use for that. I have found that seeing the patients myself and looking at their MELD scores has been pretty good for me over the years to predict how people are going to do. Volume is probably as accurate as anything, and we're getting better and better at estimating this. And there's a lot of techniques that are beyond the scope of today's discussion to increase volume, including portal vein embolization or dividing the liver partially and dividing the portal vein and waiting a while and then taking the patient back to the operating room. I think a lot of things in surgery that are empiric. This was an idea, and now we're kind of going back to the lab to try to figure out why this worked as well as it did. And so that's always a little concerning, but nonetheless, that's how the field gets pushed forward. Well, I'd like to run through a few cases, and we'll kind of try to shift from anatomy into biology as we go. But sometimes anatomy is really all that you need to know. And so this is a patient that got referred over fairly recently at the VA. He's a 75-year-old guy, a former pilot who was pretty active, but developed kind of this sudden onset over about a month period of mid-epigastric pain. I didn't think much about it, but it really wasn't getting better. And then he started noticing that he had difficulties with fatty foods that he had never had before and worsening GERD, despite the fact that he was taking a lot of over-the-counter Prilosec and Tums and things like that. He got concerned when he started losing weight, and so he went to see his PCP, and they thought, well, this guy's probably got cholecystitis. They got an ultrasound to look for stones, and they were surprised that it showed a little bit more than they expected. In fact, they went on to get some more imaging. And this patient, you can see, has got a pretty big, homogeneous, cystic-looking lesion that's taking up segments 2 and 3 of his liver. And it looks like segment 4 is probably squished in there, but has some flow to it. And the other thing you can see is that this thing is pushing into his stomach. So his symptoms are pretty obvious. This thing seemed to be getting bigger, he thought, in his abdomen. So the recommendation with an anatomic abnormality here, and obviously quite a bit of his liver left, was simple surgery. So Doug Hirth and I took this guy to the operating room, put a scope in. It was a little more complex than I expected. When we looked at it, we popped a wolf needle in thinking we could just kind of fenestrate or unroof this. And a lot of kind of chocolate milk fluid came out and a bunch of what looked like dead liver. We were able to resect this laparoscopically and put it in a bag. Patient did great, went home the next day, and I was surprised that it came back as a ruptured hemorrhagic cyst. I don't know when this ruptured, but kind of looking at the films and putting the case together and the dead liver, clearly he had some type of a vascular accident which had become symptomatic. Sometimes anatomy is a big deal, but there's a little bit of biologic concern. So the next case I'd like to run through that needed extirpation was a 70-year-old gentleman He had kind of been in and out of the VA system, and at some point somebody had documented that he had a large hemangioma. So it was greater than 5 centimeters at 7 centimeters back in 2010, and they thought this might be responsible for some vague abdominal pain he had, but he didn't really get any treatment. Finally, 7 years later, he was getting followed by the hematologist, and at this point he was complaining of early satiety, getting up every hour at night to urinate, having trouble with activities, and they had noted that his white count, platelet count, and hemoglobin were all starting to drop. They somewhat astutely recognized that he might have Kasabach-Merritt syndrome from this 7-centimeter angioma, which hemangioma seemed unusual, and they also thought maybe it was just this lymphoproliferative disorder that they couldn't work up. So again, they obtained some axial imaging and were surprised that he no longer had a 7-centimeter tumor, but had quite a large tumor. Talking to the guy, it was pretty obvious that he was uncomfortable, and we felt like a resection would be a good step. Now, this is a pretty large lesion. I think that, for those of us who do resections, realize that it could be difficult with such a large lesion to get inflow and outflow control. And having run into a case like this before down in Dallas, I called Dr. Reese and Dr. Bell to get some help. You could see when we took the guy to the operating room that this was obviously a very large lesion, and in fact, we started with a midline incision that goes all the way from the xiphy sternum down to the pubis, and this liver occupies his entire abdomen. I was pretty pleased at this point when Dr. Bell and Dr. Reese showed up and extended our incision. That allowed us to get proximal and distal control for this patient. And he did well. Post-operatively, he was able to go home on day 8. I saw him back in clinic fairly recently. He's gained 10 pounds now. His white count is normal. Platelet count is normal. And I think if you look at the literature, there's not a lot of cases. There's supposedly only 11 reported cases of this before, with average hospital stays between 15 and 60 days. So, in this instance, I think the risk of the big incision was probably worth it for this patient. We'll move on a little bit, because again, it's a large topic, to more biologic and probably less anatomic concerns in patients. I think, mostly what you think about when you say extirpative therapy is cancer in patients. And this is where I think that perhaps as surgeons we can do a better job as translational researchers and try to push the field out of empiric therapy and into something that's a little bit more scientific. This is an interesting ad that I saw recently. Is a company that's developing a microsphere product that will directly put chemotherapy into tumors. And this was their artistic conception of how their device would work. And it's nice. I mean, you can see there's little beads going into a catheter. And they've got another catheter set up to take them out to reduce cytotoxicity. So this is, I would say, in talking to my father-in-law, who's a mechanical engineer, his idea of how you would design a perfect treatment for cancer. But I think it's a little harder than that. It's not really enthalpy, right? This isn't a snowball that we're trying to melt. We can't say that, gosh, I'm just going to keep putting hot water into this system, and eventually it's going to change the energy state of the snowball, and it's going to go away, and I'm going to accomplish what I want. And in fact, if you look at a cancer cell, and this is a well-differentiated, it's not too bad, cholangiocarcinoma on the top, you can see that it's very irregular. I mean, where are the vessels? It's hard to tell. Cells are different types. The architecture is distorted. And so, it's difficult to deliver drugs. I think our research colleagues, started getting more of an idea on this when they came out with Avastin, or bevacizumab back in the early 2000s. This was going to be an anti-angiogenic agent and kill all these tumor blood vessels, and things were going to work well. Started giving it to patients, and lo and behold, it didn't work as well as they thought, or we thought, and it didn't work the way they thought. So this is some interesting work where Rakesh Jain kind of first recognized that, gosh, tumors aren't like screen left. I mean, they don't have regular, arterioles coming in and venules going out, but they've got high hydrostatic pressure and these real irregular blood vessels, and perhaps the way Avastin or some other drugs could work would be to normalize this system to allow us to deliver chemotherapy more readily to tumors. And so I think it's a good idea, and I think that's something that we need to work on, is to deliver cytotoxic drugs to the place that we want them to go. I think the next problem that we need to recognize is not as simple as just getting a drug in. This is, a quote and from a lecture that Don Morton gave. I got to spend some time with him in Dallas before he passed. But, the Skipper-Schnabel-Wilcox model of drug delivery and cytotoxicity was developed by physicists in the 50s. Basically, it's a log-kill model. It tells you that for a given chemotherapy, you can count on killing a certain number of tumor cells. And it makes some assumptions, right, that these are homogeneous cells. They're all sensitive to the chemotherapy you're giving. But that's not necessarily the case. And in fact, even if you had a really good chemotherapeutic agent that killed 90% of the cells, the 10% that are left are going to be enough to eventually go on and take a patient's life. So it's really a palliative treatment in many senses. I think the other problem you get into is there's a lot more tumor cells than we think about. And I will apologize to the residents. I think, like many, I have quoted incorrectly that a 1 centimeter epithelial tumor has 1 billion cells in it. I went back and actually looked that up, and that's from some old data where they grew cells in vitro and measured their volume. But there's still a lot. I think the other thing that you talk about is we usually get tumors that are in the 3 to 4 centimeter size, sometimes larger. Even a 5 centimeter tumor, if you have a single one, is going to fall within the kind of easy criteria for liver transplantation. But you can see how the cell numbers go up quite exponentially, and a 5 centimeter tumor of epithelial origin is going to have as many cells in it as there are people living on the earth. So it's not going to be easy to deliver drug to these patients. So leads us to say, well, gee, we don't need any chemotherapy. We'll go back to the black box and start saying we should just operate on everybody. And that definitely has a role. I think that if you go back and look at the literature for liver resection, for colorectal metastasis, there was a study, the Hughes paper that came out in 1988 in surgery that showed that a certain group of patients, about a quarter, will be alive at 5 years without disease. Unfortunately, and I think disappointingly, despite advances in technology and our ability to do more resection, we really haven't pushed the survival curve that much. This is a paper from Minagawa in 2000, one from Tim Pollack, and then a pretty recent paper from Holland. If you start looking carefully at the 5-year survival, we haven't, just with surgery and giving systemic therapy, been able to bump that up maybe as much as we like. So I think surgery alone isn't an answer. I think recognizing that the delivery of cytotoxic drugs or molecules to these patients is a little bit more difficult than maybe we have anticipated can lead us into some other therapies. The next problem is a lot of patients aren't candidates for surgical resection. So depending on where you look in the literature, somewhere between 5 and maybe 35% would be a candidate for resection. So we need to think about other therapies since we can't get drug into these patients. I think surgery is going to fail for biologic principles. All we can treat are the things that we can see, so the top of the iceberg. But there's obviously a lot of tumor cells running around that can cause trouble. This is an unfortunate patient I did a Whipple on when I first got out of my fellowship, and she did great for about 8 months, and then she came back and got a scan and had a single lesion in her liver. 3 months later, we were talking about whether or not to give her chemo or what to do. She got another scan, and she had blossomed a lot of disease. So, it's a difficult problem. I think not a lot of patients are potentially candidates, and so alternative therapies that could extirpate or destroy some tumor cells or potentially help our colleagues in medical oncology do better are of interest. And so I'd like to just run through briefly, in the interest of time, some of these today. Should we go? RFA, I think, kind of came on in the 90s. Actually, was a engineer whose wife was told she had unresectable hepatocellular cancer, who developed this company, Radiotherapeutics, and essentially what he did was apply the Joule-Lenz law, and this is a variant of the Ohm's equation, but it basically says that you can produce heat in a tissue by modulating current, looking at resistance, which would be in the liver itself, and time. And from this, radiofrequency ablation kind of came into being as one of the early heat therapies that was widely distributed. And the idea, obviously, is you could put a probe into a tumor, open these tines, and generate heat, and then you can modulate either for temperature, for resistance, or different indices to destroy tumors by necrosis. And this was really popular for a while. Probably got too popular and was overused. The results were a little bit disappointing. But I think it's worth looking. Now, we have switched at the VA fairly recently to microwave therapy, but Arata came and helped me take a look at how we had done, just kind of comparing RFA in our patients with hepatocellular carcinoma. So we looked at the last 385 patients with HCC that got referred in the RFA era at the VA hospital. And of these patients, we found that 107 had been offered either TACE, RFA, or both. So we wanted to look at, well, how do they do? This is just a simple study trying to categorize these patients. And interestingly, and not surprisingly probably, what we found was that at 2 years, the patients that got TACE alone didn't do as well. There was about 36% alive after their initial treatment versus close to 82% alive if they got TACE followed by RFA in this group. At 5 years, the results are really pretty equivalent to what you would see in the published literature, but RFA was still better than TACE in this group. So I think it does at least give us a starting point to say there is some benefit to delivery of cytotoxic drugs and to giving patients some type of extirpative therapy. And the conclusions, I think, kind of looking at this, is that getting both is better, and that's probably not that surprising. It may be worthwhile in these lower morbidity procedures to consider doing this more than once. When we looked at the trial to try to figure out, well, how did they decide? It really was anatomic location. So things that they couldn't easily get to with a percutaneous approach only got a TACE, which doesn't make any biologic sense, and something that I think as surgeons we can help address. And then there's some technical issues that obviously can be addressed in this large HCC population here in the Denver area. Well, RFA is not perfect, and I think it's important to look at the literature. This is a nice study that they did at UT Southwestern. Danny Scott was the lead author, but they wanted to see, does this really work as billed? And Danny was always kind of a little bit of a skeptic. So he took pigs, gave them a blue phantom lesion made out of agarose gel, and then tried with the help of the radiologist to do ablations. And what they found, it was harder than they thought. So you could see at the liver picture, it's a little dark, but basically it was hard to get a good margin. And if you don't hit this correctly, basically you didn't create with the tines the burn shape that you wanted. So they had a 33% positivity rate in these pigs, which is a pretty relaxed condition in terms of doing that. So I think it's important to keep that in mind, particularly in terms of location and the use of technologies if we're actually accomplishing what we think we do. Well, we've made I think some advances on that and some efforts to control for the difficulties with the machinery. Microwave really is just probably a next step in this regard, where you're going to use an antenna now to vibrate water molecules to boiling temperature with the idea that you would get, again, heat necrosis. This is a little bit more complex, and so you can control where the waves go in a more variable manner and some feedback. The engineers are pretty excited about that. And it sounds great, and we're using it. I think it's easier in terms of time, and a little bit easier to place these antennae in the operating room or laparoscopically than perhaps it was. You don't have to worry about sticking tines into the diaphragm or places you can't see laparoscopically. Is it better? I don't really know. This is a nice meta-analysis that was done by Lou, looking at a variety of studies. This is an Asian set of trials, and so you can see that they also looked at percutaneous ethanol injection. And, unfortunately, when you try to compare microwave to RFA, we're hovering right around a confidence interval of 1 in these. So probably not a lot better if done well, but I think it has potential to be developed further. It's something that we will look to see get better and better in the future. Another new treatment that is kind of coming on the horizon is this irreversible electroporation. The idea here is that pulses of electrical energy are going to create these permanent holes in cells. Now, theoretically, if you have cells like vessels or bile ducts that have a lot of gap junctions because they're endothelial tissues, they would not be as susceptible. And so this may be something that can be used for central lesions that have not done well with high heat. In fact, this is a fairly recent study from Sloan Kettering where they looked at the use of IRE in patients that weren't otherwise candidates for microwave or RFA or resection. And they found that for small tumors, this was actually pretty good. They created a fairly large ablation zone in these patients. They noted that if you didn't have any recurrence locally in the area that you treated at 19 months, they didn't get any, and this is 40 patients with 77 lesions. I think one of the unfortunate things in America was they noticed that if your body mass index went up, that this was less effective, and they postulated fatty liver doesn't respond as well to these tumors. So that's something that we will be looking probably to use in certain anatomic situations more in the future. And finally, you can't beat technology. I think we're fortunate here at the University of Colorado to have one of the outstanding radiation oncology departments in the United States. And Tracy Schefter has really led the efforts here. She was a bad name when I was at UT Southwestern because that's another famous place for the development of this technology. And Tracy was able to get this study together, put it out in the Journal of Clinical Oncology back in 2009. Bob Timmerman got his trial done in 2010, so he was a little behind. But basically, the idea, and I think this is something that's also exciting, probably in some ways more so than microwave, is that you can target multiple tumors at one time and have the ability, as we get better and better resolution radiographically, to deliver high doses of radiotherapy and completely damage these tissues. Now, it's still susceptible to high recurrence rates, just like other treatments of the liver, again, getting back to biologic principles, but the ability to fairly rapidly, within 2 or 3 sessions, give high doses of radiation for metastatic or primary liver lesions without incisions of patients is something that I think we can look forward to as we move forward. So I think in conclusion, it's a little difficult to put this together. I mean, there's a lot of small series, and Dr. Perlman's right. This really is empiric therapy. I think, when you get sent a patient to evaluate them, if it's a simple anatomic issue or a more benign biologic issue, makes your decision fairly easy, and mechanical problems are pretty easy for us to figure out in the operating room. I think that the data, albeit somewhat confounded, suggests that combinations of extirpation and systemic therapy are best. And the challenge, I guess, for the residents, because you do go through your career more quickly than you think, and the students out there, is to continue to address this difficult problem. And I'll leave you with a quote: "It's better to light a candle than curse the darkness." Thank you.
Do we have time for a question or a comment? Anyone? Dr. Stigman.
Carlton, that was a nice summary. A few years back, people were looking at extracorporeal microwave hyperthermia. Has that gone anywhere? Does it get any traction, or is it a flop?
I am not familiar with that. I mean, these technologies kind of rise up and have some interest. I think they're small series for looking at that, but I haven't seen a lot with that. I would say, just kind of like the radiation, is probably something as we get smarter that we could look to see. I guess my feeling a little bit is we probably need to do a better job working with our engineers who are pretty eager to help with these problems, to explain a little bit more about the biology that we're dealing with than perhaps we have done in the past. It's not, unfortunately, quite simple.
I mean, theoretically, it should work as well as RFA or microwave ablation, because what it does is it heats tissue in a localized area. But I think the technology for accurately delivering it is still an issue. Carl, in your study where you looked at the VA population and the TACE plus RFA did better than the TACE alone, did you separate out for size? My guess is you didn't try to RFA the larger lesions, and they have worse biology, and they did worse.
Yeah, I think that's a great thing. It actually, it was anatomic location was a separation. There was not a difference in the size of the tumor, but it was, the majority of this was done by interventional radiology, and so anything that was close to the diaphragm or visceral structure, they couldn't get to, regardless of the size, got TACE alone. And so it's actually kind of a nice study in that regard, and there wasn't a significant difference in that. And so I think, having full-time, service over there that can drop the falciform suspensory ligaments and triangular ligaments and allow these things to be stuck fairly efficiently will probably change the data. And so that's one of the new trials that we're getting set up with those guys right now. But we see a lot. We have about 80 patients a month at the VA that have new liver lesions. So, yeah, it's a pretty large population.
Okay, great. Okay, why don't we end it there? Thank you very much. Great job.
Thanks.